Oh, perfect. You want to share your screen?
Yep.
Let me enable it.
Okay, should be up now. You got that?
Mm-hmm. I am. Yep.
All right, cool. So we'll let people kind of trickle in here as we're going over this stuff. Like I said, there shouldn't be too much here that either Jim hasn't gone over in some of his pre-course
Mm-hmm.
videos, or that we won't be able to discuss during the actual lab session. But it is good to kind of get a foundation for some of this stuff. There are some things that I want to touch on, at least with some of these typical pathologies. So most of the stuff that's left on here, this is just the end of the presentation that we were going over the last couple of weeks. I do think it's nice to go through some of the pathology stuff, looking at some common referral regions. So heart stuff obviously is a big one in the thorax. Um, one of the major things that we have to consider is that it's very rare for mechanical problems. So, musculoskeletal problems in any region of the spine to present with peripheralized symptoms and no local symptoms. So that would be, for cervical spine, that would be it just presents with arm pain only, with no local neck pain. That's a relatively rare presentation. And it's the same is true of the thorax. So when we look at that and we have arm pain that's associated with the trunk, we have to start to consider that is a possibility that it's associated with the cardiac mechanisms, as far as reference pain goes. Same thing with the lung, but we have to take that in consideration when we're looking at the potential for peripheralized pain coming from the spinal segments or from the rib cage itself. Okay. The other one that I want to touch on here is actually most of the stuff that's kind of in the upper quadrants of the abdomen. So the liver and the gallbladder and the spleen, especially, they have their own particular reference areas, anywhere from about T6 to T10, depending on, which text you may be reading, liver and the gallbladder, similar sort of things. And this will tend to be referenced on the same side as the organ. So left side, mostly with the spleen, liver, and gallbladder will be more typically on the right side, depending on the orientation of the gallbladder to the liver. But there is also the possibility with an acute inflammation of some of these organs, that it will actually irritate the diaphragm because of its relative location next to the diaphragm. So what we can get with that is a reference into the upper quadrant, and it's typically into the upper portion of the supraclavicular region, the trap area, those sort of areas in the upper shoulder. A lot of times it's described as an irritation of the phrenic nerve, which you could take it or leave it as far as whether or not you want to believe that sort of thing. It could simply be a misinterpretation, like a typical reference pain of the cortex, that's actually just presenting this pain in that sort of area. So if we have a patient that presents with upper abdominal pain, which could be an area of mechanical dysfunction, it's very common with the lower ribs to present with upper abdominal pain because of irritation and damage to the interchondral joints. Things like that can give us kind of that upper abdominal irritation. But if we have a significant reference into the supraclavicular area here, that could essentially lead us to believe that we're dealing with more of a true visceral pain. Okay, so we have to take those sort of things into consideration as well. Now, again, these sort of things will be irritated by things other than movement of the trunk. Okay, and I think that's kind of a lot of what's on this next page here. But if we essentially have them doing rotation, flexion, extension, etc., of the trunk, but we're not reproducing pain, and they mention that this is postprandial pain, meaning it's after they eat, something along those lines, and that's when these sort of pains come on. Again, that's another suggestion that this is not a biomechanical lesion, that this is more of a visceral issue, and we need to get them the appropriate diagnostic processes. Okay, so again, that's kind of the stuff we were talking about before. Thoracic wall pain, they should have a good musculoskeletal explanation. Otherwise, we end up having to start to consider the idea that we're dealing with more of a visceral issue. Any questions there? Hopefully not. It should be relatively straightforward. Visceral pain in general, as far as descriptions go, what a patient might describe to you as they come into the clinic, deep, diffuse, and aching is kind of the most common clustering of descriptors that we get with this sort of stuff. So it tends to be very difficult to localize. It tends to kind of wash over the patient. So that's where that wave-like description comes from. And again, it's not associated with movements of the trunk, right? These are things that patients talk about after eating, after exertion, with breathing, things of that sort of nature. Certainly can be triggered with stress or emotion, tends to affect some of that sympathetic mechanism as well. Visceral pain, when we have to think about this, there are sensory nerves that enter into the dorsal horn. Most of these will be due to somatic afferents, right? So these are things that are coming from the musculoskeletal system, but there are, for about 1 out of every 1,000 of those type of nerve fibers that enters that system, there are some sensory only collaterals that will enter there from the sympathetic system as well as from the viscera. Okay, but these things, like I said, are sensory only. They are not able to be affected as efferent mechanisms, meaning you cannot, and I stress this a lot here with this big capitalization down in my notes, you cannot affect an organ with movement of the trunk. So when you hear other professions trying to talk to us about how they're going to do something to your wrist or your hand or your foot to affect your liver function and things of that sort of nature, they're not talking, they're making that sort of thing up, right? That's not something that has been well proven, at least by significant research. So make sure that we're confident of this sort of thing when we go in to look at patients, because it's just something that's not diagnostically correct. All right. And again, Jim, this slide, Jim has gone over this. He gave you guys, I think it was like an 11-minute video or something along those lines on cardiac pain. But it's always good to touch on again. And there are some things in here that we can talk about as far as reference pain, how that mechanism works, that I do think helps with remembering some of these issues that can come up, especially some of the ones that are less common, less well-known. So the typical presentation here is that type of crushing, pressing pain. I think there's something like 37 different descriptors for chest pain. And every one of them has a very unique diagnostic mechanism to them. We're not going to go through all of them, at least not today. We may go through a few more of them when we get into the class here. But any one of these sort of descriptors can lead us to believe that there is potential for cardiac dysfunction here. Okay, so certainly if it's related to exertion, some of these things may radiate up into the neck, may get into the jaw, down the arm. It does not have to be medial arm pain, doesn't even have to be only left arm pain. It depends on which portions of the neurologic system are being affected by this sort of cardiac event. Okay. The biggest thing with this, and as far as the reference of pain goes, is the association to the sympathetic system. Things like sweating, clammy hands, nausea. These are things that can present as symptoms of a cardiac event. It is more common in females. It doesn't necessarily only happen in females. Things like intrascapular pain as opposed to chest pain, that crushing sensation that people tend to most commonly report. Those are more common in female victims to cardiac issues. But the attachment to the sympathetic system is the thing that I wanted to mention on this. Okay, so when there is pain response coming from the cardiac mechanism, right? So when we're dealing with essentially a myocardial infarction, something of that sort of nature, it does affect the sympathetic system. You can see down here in my notes, this is where it's described here. tends to start at T4. Okay, that's the associated innervation of the heart, which will tend to give us that initial chest or mid back pain. And then what will tend to happen with that is the signal will tend to travel upward through the sympathetic ganglion. Okay, so it'll move up to the stellate ganglion around T1 or C7. That tends to give us that medial arm pain. And then from there, it'll move up the next most prominent sympathetic ganglion, which is about C2-3, which tends to give us neck pain and or jaw pain. Okay. All of these sort of references will depend on the individual anatomy of the patient and where the sympathetic ganglion may lie. They can be relative anatomical variances from one person to the next. For instance, we could have pre or post fixed plexuses, which may mean that the typical neurological structures at C2-3 or C7-T1 are either prefixed, meaning they're one segment above, or post-fixed, where they're a segment below. Or it could just be where those sympathetic ganglion have formed for that individual patient. So the references may be slightly different. And again, that's one of those things that may give us lateral arm pain with a C6 innervation as opposed to C7 or T1, which would give us more medial arm issues. What else was the other thing that I wanted to talk about with this? There is a possibility a lot of these sympathetic nerves are affected by vascular conditions, which seems to make a lot of sense. So if people that are like diabetic, for instance, may not have some of these responses. They may have cardiac events without things like severe chest pain. So they will tend to have more of these types of symptoms where they have more sweating, more of that, they call it a silent heart attack, something along those lines. So we have to be aware of that sort of thing if the patient has other vascular conditions, something that affects the vascular vessels, the blood vessels. Things like diabetes, for instance, can do that to us. Again, Jim went over a lot of this, so I'm not going to spend a ton of time on this sort of thing. Neuromusculoskeletal pain could have either somatic, which is more of a deep and aching, that's more of a typical reference pain, a referred pain, or a neurological pain, which is our typical lancinating pain, which is the kind of those lightning bolt types of pain. Could be either one based on musculoskeletal issues. And again, these things are all written down here. I think you guys have access to this sort of stuff. But true neurological pain can be lancinating, could be causalgic, could be something like paresthesia that is associated with that. But it's really rare for us to have referenced pain. We talked about this a second ago, without trunk pain. So neurologic pain, especially if we have something that suggests referenced neurologic pain, this is whether it's from the thoracic spine, the cervical spine, or the lumbar spine, but it's in the absence of what we would consider dural symptoms, then that tends to be a red flag. Okay, and the reason for that is that if we have these acute neurological pains, but we don't have the associated dural symptoms that go along with it, meaning tension on the dural system, then it tends to suggest a slow growing or slow developing lesion, something like a tumor, something like an osteophyte, and usually is not a good sign when we have that sort of thing. So we need to be conscientious of that as well. Okay, what else we got here? Disc herniations. Again, Jim goes through a whole video on this, so I'm not going to belay the point with this sort of thing. Very commonly, as with most herniations, the pain should be severe. In the thorax, they're very rare. One thing that I don't think I mentioned during the anatomy discussion is that thoracic discs occasionally will produce clefts, meaning that they'll actually get indentations in them to facilitate rotational components. So again, I think that plays a role in the reason that we don't get a lot of herniations, or at least symptomatic herniations within the thorax, is because the discs are just comprised differently, and some of them will develop this clefting. So again, not a very common problem for us to pop up with, and it could be just that we're not looking for them as often. But when you get down into these areas where, and I think the numbers Jim presents with are from different studies than the ones that I've used here. I think Gail gave me a lot of these numbers here, but relatively speaking, they're still very low numbers. Most of them will occur below T8. And I think most of them are actually at, I think it's at 30% of them are at T11, 12. Yeah, 30% at T11 and 12. So those sort of things, when you take it into consideration, T8 through T12, they're more consistent with, they start to develop more consistently like a lumbar disc. So it's more possible to have herniations in those sort of areas just because the morphology tends to start to match up a bit more with the lumbar structure. Okay. The ones that do develop things like lower limb pain, they almost all of them are going to end up having to have surgery. And I do have a, it's an anecdotal thing. It was relayed to me from another therapist about a thoracic disc herniation that was present, that was actually first found during one of the oral practical exams. So I usually tell that story when we're going over safety tests that we have to do before doing most of our examination process, and definitely during our treatment process. So we'll talk more about that, but it makes a lot of sense that if we have a patient that's developed lower limb pain due to a thoracic disc lesion, that they're going to have surgery, because the only way they can have lower limb pain with a thoracic lesion is if they're presenting with upper motor neuron symptoms at that point. So that would make a lot of sense that they have to have that decompressed in order to correct that issue. Okay, so a little bit of reference here. That's mostly just the stuff we were talking about up here. Okay, now here's a couple of little things that I do like to talk about pretty consistently on courses. The optimum spine, it was actually written by, I think he's a physicist, if I remember correctly, or maybe a mathematician. It's an article based on the movement of the pelvis and lower limbs during gait. Now, it sounds very much like a medical or a physical type of article, but it's very mathematical based. I've actually read it, and it's so confusing. It gets into all these different things, of which I'm not going to mention, but there are some important points that I want to talk about. Specifically here, things like locomotion, it's not produced by the musculature of the legs. It's much more consistent and well studied at this point that it's generated via the pelvis through the psoas major musculature. The legs are just basically elongations. They're basically just long pendulums to help improve the efficiency of the gait mechanism for us. So do have to overcome inertia. So if I'm standing still and I have to get going, we have to overcome that sort of mechanism. And that does require some recruitment of the lower extremity musculature. Things like the calf muscles, particularly the soleus, will drive that sort of thing. But if we're looking at the attachment of the psoas, and again, this gets into a little more of the lumbopelvic mechanism than it does the thorax, but the thorax becomes very important for it. That's why we're going to discuss it here. It attaches to the anterior portion of the vertebra and the anterior portion of the transverse processes. So if we think about that attachment point, what's that going to do to the spine when it either elongates and stretches, excuse me, or it contracts? It's going to produce a lordotic curve, right? So it's going to pull the lumbar spine into extension. It's going to produce an ipsilateral side bending. And then if we think about that transverse process being pulled forward, it's actually going to produce a contralateral rotation. When we think about that, that is a contralateral coupling, right? So we have, say, right side bending with left rotation in extension. That's a very dynamic position for the spine to be in, okay? And it's actually one of the mechanisms that we look at as far as testing the thorax, because we have to produce a side bending first and then a contralateral rotation for combined movements. We'll get into that during the lab lab session next weekend. But the idea here is that because of the movement, what it produces through the lumbar spine is not designed to rotate. And maybe I've mentioned this before, but the lumbar spine, because of the thickness of the discs, because of the thickness of the longitudinal ligaments, because of the orientation of the facet joints where they face straight forward and backward in that sagittal plane, the lumbar spine is not designed to rotate at all. It's really designed to resist rotation, which is a good thing. If we get into the actual if we're starting to think about the actual structure of the bone, of the joint capsule, of the ligaments, of the disc, these sort of things, they're very plastic structures. They have a great deal of pliability to them. When we tend to think about things like bone, we don't tend to think about pliability very often, but they're actually very, very malleable in most cases. Okay, so the article here that he's written does postulate that all of these structures, so bone, ligament, fascia, joint capsules, they're not just there to resist motion. They're there as elastic structures to help produce this torsional motion that creates this spring mechanism. Down here in the notes, we think about this a lot in looking at the twisting of like a plastic ruler, right? So, you know, the ones you used to have when you were in grade school. If you take that and you twist it in opposite directions, and then you release one end of that, it's going to spring directly back to that flat position, right? It's going to just restore its normal morphological structure. Very similar here for the lumbar spine, right? So if we get into that kind of twisted position, lumbar extension, side bending, and contralateral rotation, when we lift the heel, essentially that exact same spring mechanism occurs. And so it gives us a very, very efficient mechanism for gait in order to help generate passive energy. This allows us to use a relative minimal amount of muscular effort to continue to propel ourselves forward. Very efficient, and it's unique to humans because of the ability to get into a lumbar lordosis, the ability to get into hip extension, and the ability to produce what they call an anterior torsion of the sacrum. That's something that we won't be touching on any, at least not in this course. Something we'll get into in the advanced lower module, which I think it's 5. I can never remember if it's 5 or 6. I think it's 5, but those are 3 very unique mechanisms to the human locomotion. Okay, and so we wouldn't be able to do this without those sort of mechanisms, but it's super efficient. And when we look at it from that perspective, we have to consider the idea that we need to be able to produce this spring. And one of the major mechanisms for us to produce this is the ability to produce trunk rotation through the rib cage. If you look at somebody that's taken a stride, somebody is right at heel strike, so before heel lift on the opposite leg, say if we have our left foot forward, we would also have our right arm forward, right? That's the typical stride position that we get into when producing gait. So the lower half is moving in one direction, essentially with the left foot forward, the pelvis would be facing to our right. With the right arm forward, the trunk or the thorax would be facing toward our left. So we're producing this torsion very easily in that situation. But if we're not able to generate that rotational component through the thorax, we have to make up for that energy somewhere, right? So either we have to start pulling with the psoas, we have to start pushing with the calf musculature, so the gastroc or the soleus, we have to start pulling with the hamstrings, or any of the different musculature of the lower extremity tends to have to kick in order to add that energy back into the system. And it's the same for any portion of the body in this sort of situation. If we lose, for instance, talocrural mobility, and we can't produce we can't produce efficient dorsiflexion of the ankle. A lot of joints in the foot that produce a lot of stretch, right? So a lot of joint capsules, a lot of ligaments that are able to all elongate, twisting of the foot to produce that sort of spring mechanism. Then when the heel lifts, it should all be released. That energy should translate up through the Achilles into the calf and even through the peroneals toward the fibular head, where it'll attach to the biceps femoris, and that energy can continue up toward the pelvis. If we can't get into appropriate dorsiflexion, we have to add that energy back into the system. We do that most often by pushing through the calf. Very easy for patients to start to develop an Achilles tendinopathy or cramping or discomfort within the calf muscle itself. It happens all the time. We see it a lot. So again, if we can't do these sort of things through the thorax, because this is where we're kind of focusing, we have to add that energy back into the system somewhere, right? And because the thorax has so many joints, has so much pliability to it, it's easy for us to end up distributing a lot of that load through the lumbar area. So very easy for us to start to break down the lumbar structure, lumbar neural arch, the disc, the joint mechanisms, the ligaments, etc. All those things can start to break down as they start to exceed their adaptive potential. So it's really easy to see how movement through the thorax becomes very important when we're talking about things like locomotion. And again, we'll go back through that a little bit more during the course as well. Okay, I always like to talk about efficiency of motion when we're dealing with the thoracic spine, mostly because of how it affects our rehab potential. So when I talk about rehab, I'm usually talking about movement re-education. I'm talking about strengthening. I'm talking about those sort of things. The manual therapy components I usually look at as a separate portion of our treatment protocols. But because of things like innate physiologic tasks, like having to be able to breathe and produce adequate posture to resist gravity, those sort of things that we can't get away from. We can never escape gravity. We can never stop breathing. We have to have some sort of compensation if we have dysfunction within the thorax, right? So I like to use the efficiency mechanism when I'm designing my rehab protocols, because I know that the body has these innate patterns that are available to us, things like gait, things like respiration. The body has these innate protocols that it uses to produce these movements. But when it has to, because of anatomic variability or in particular biomechanical limitations, it has to make compensations, and it starts to develop these compensatory movements and these patterns with muscle recruitment, with motor patterning, all these different things, timing, all this sort of stuff comes into play. And so the body just goes through these habits over and over and over again. We think of something like respiration, with how often we have to take a breath. It's very easy to see how these habits become difficult to break when we're looking at things like thoracic lesions. Right. So I think this, and I think I've mentioned this in the past, but I do think this is one of those situations where it's part of the reason why thoracic lesions are so difficult to maintain once we've done a correction. We go in, we do a great examination, we do a perfect manipulation, everything's moving well, and then 3 days later, it's right back where it was. It's probably because of these innate compensations that the body has to make, at least potentially. So again, we like to use these natural processes and these natural efficiencies to let the central nervous system take over and decompensate these compensations for us. We'll talk a lot about how we do that stuff when we get toward the end of the module next week. Just some of the methods that I use for that. But again, I prefer to use these sort of things when it comes to rehabbing the thorax, just because it tends to be a lot simpler, and the body tends to pick up these mechanisms and their original patterns much better. But if we're looking at things like locomotion, if we're looking at things like athletics, for instance, things like body tension tend to play a role in how efficient we can be, right? So if we look at, and I'm a hockey guy, so you guys will hear me use hockey terms all the time, but efficiency of motion or economy of motion, if you look at, for instance, hockey players, like you watch a Connor McDavid skate or a Cale Makar skate, and it just looks completely effortless to them. It does not look like they're laboring. Looks like they could do this sort of thing all day long. It's because of the lack of tension that they have in their body. They're able to utilize this sort of economy of motion because they can produce these passive springs, because they can produce these this sort of efficiency of motion. Right. If we look at things, so I always talk about, and I coach hockey, and my son's real big into that sort of stuff. So I'm always trying to tell them to play without as much tension as they can, because when you're trying to produce something quickly, the more tension you have on that particular body region, the slower you're going to end up being. Right. So this becomes very important when we talk about things like manipulation. If we are tense, if the body region that we're going to use to produce our manipulative thrust is tense, we are going to be slow. If that body region can be relaxed and tension free, we're going to be much faster. And we're going to talk a lot about different ways to produce that, because we still have to engage our barriers. But we want to be able to do that without engaging the body region and the body parts, at least, that we're going to use to produce our thrust. Okay, so we'll even go through some practice stuff in order to help kind of get you guys used to that sort of stuff. Okay, any questions there? That's really all there is on that stuff. And you guys should have access to this stuff now, so you can go back and look over it if you feel the need to. Any questions? Any comments there for me, Dave? Anything else you want to add?
Now, but I think we should keep talking on this thread because this is interesting. I don't think it's worth shifting gears at this point. Whether we chat about locomotion, thoracic position with normal movements, our patients. I mean, it's just a nice segue because, getting even into gait in the thoracic spine.
Yeah, and I think when we look at it, it's really easy to get caught up in the minutia of it. We get
Mhm.
sometimes so focused on the individual body area that's either producing pain or that we think is dysfunctional and could be affecting other
Mhm.
body regions. We don't look at it from a whole. Um,
Mhm.
and things like gait, I mean, it's pretty obvious it occurs throughout the entire trunk,
Mhm.
um, all the way down into the foot and the ankle. And so it's really easy for us to kind of just focus in on one particular area. But we can have patients that come in with thoracic pain, mid thoracic pain even, and the source of it could be a stiff ankle. We see this a lot more consistently, I think, in the lumbar area,
Yeah.
but it's definitely something that can happen.
Mhm. Yeah, because that inability of the rotary forces to kind of move through the system and where they're getting trapped. I mean, who doesn't have a patient right now that has basically a relatively kyphotic upper, thoracic spine?
Yeah.
And, what does it immediately do to the gait? And who's seen that? I know Abby has. Abby sees a lot of it. Don't you, Abby?
Someone right now. I'm thinking about that patient, Dave.
How do they walk? Your mind. What's in your mind?
Um, there's not much rotation in the trunk at all. It's pretty much all like hip rotation, and he also has a
Mhm.
lot of like hip weakness.
Mhm.
But when he's having trouble running because he has hip pain, but
Mm.
he's like not moving his trunk at all. He's just like nice. He's like a stiff board when he walks or runs.
Mhm.
It's such a common profile for runners. I hate
Mhm.
it because you would expect endurance athletes to be mobile.
Mhm.
Usually they're all very slim. They're all in good shape, that sort of stuff. But for whatever reason, endurance athletes, marathoners, triathletes, etc., I see it a ton. Dave, you can
Yeah.
chime in on yours,
Oh,
but their
same body
thorax
size.
is almost always stiff, almost
Yeah.
always. And like I said, I don't really have a great explanation for it other than as they progress and they're moving into longer time frames with their particular whatever their run is, whether it's a training thing or whether it's an event, they they start to have some movement breakdown, right? So their form starts to break down. They start to stiffen here, and it's more of just this real short arm swing as opposed to this sort of thing that's helping us with that springing motion. Um, and when in reality, it would be much better for them if they could maintain that rotary component through the trunk, in order to help facilitate that passive energy generation, right? Because you see this a ton where the patients will come in and they'll be like, yeah, I'm training for a marathon. And, at name a mile 12, mile
Mhm.
16, I start developing this calf pain. So it's like, well, okay, tough to reproduce that sort of thing for them in the clinic, right? Because you'd have to have them run for however long to get up to 12 or
Mhm.
16 miles. It's not really feasible, in most cases. But we can make some assumptions here and say, okay, if this follows a typical if this
Mhm.
follows a typical routine, we can say, well, they're probably going to be very stiff through that thorax. We can look at the movement of the joints individually to see where they start to limit themselves. We can have them run, certainly, because odds are whatever restriction is there, it's probably always there.
Yeah.
And we can see it right off the bat, but we may not be able to associate it with the actual pain response.
Yeah, because you think with the thoracic spine, itself should be a spring. It should be dissipating forces, as you load. So if you're looking at even force that go in the lumbar spine, again, the lower quarter is a spring from below, but the thoracic spine should have the ability to dissipate forces through rotation and normal compression, where you see these individuals where it's almost like it's a bit of a flexed posture that gets locked in. Whether it's a energy conserving strategy to create a bit of a forward lean or an anterior tilt versus using the rotation. And maybe many times to use good form, yeah, there is a fluidity to it. And as you get tired or achy, you kind of start operating in safety mode. Is it as they get later in these races that their system, neurologically starts operating in a bit more of a safety mode? almost like what you'd see like the classic pattern of the masters or geriatric, we'll call it a geriatric runner. And it's because when you look at the older runner, their profiles are very, very succinct. They're flexed, they flex the knees and the hips, they don't get much joint range of motion. They develop this certain strategy that's very common in somebody, usually somewhere in their late 50s to 60s, you start to see it. I remember when I
Yeah.
ran with Fred, and Fred had a very fluid run. And years later, I ran with Fred, and he had a very old run. Like, I didn't want to tell him that, but he
It's
developed a
on video
geriatric
now,
posture.
so you may
Huh?
not have, it's on video now.
Yeah.
So
But
yeah.
it's a very thing, but it's that thoracic flex posture then doesn't dissipate the forces coming in. So now all of a sudden it's basically a compressive load, which is coming from above, but the rotation also helps to dissipate those forces. So yeah, you're going to
Yeah.
see this in people, and it's a harder thing to unwire. And you can many times again, you look at the lower extremities. Lower extremities are going to compensate, and this is running with this is also if you're looking at gauge in individuals, somebody who may have if they're having hip issues because their thoracic spine isn't contributing the proper rotation, they're flexed forward. It's going to change their muscle patterns in the lower lumbar spine, hips, kind of compensate for that change in center of mass and that lack of rotation and efficiency.
Yep. Well, and once you it becomes problematic when you start to develop any type of lumbar issue. Whether it could be lumbopelvic, could be TL junction. The psoas goes up as far as T12, at least at least definitively. There's some conversation in anatomic text that it actually continues up the spine, but doesn't affect hip or pelvis movement after that, and it actually is an association with the longus colli by the time it reaches the cervical spine. Fred used to give me that speech all the time that he thinks it's actually all one continuous muscle. I don't really have any reason to argue with that, but the thought process is there that anything that gets up to into that TL junction, or should say down into that TL junction, can affect hip flexor tone. So for instance, Abby's patient that's having hip issues and is a very stiff thorax, if it's a gating mechanism there at that TL junction that's causing increased hip flexor tone, we talked about what it's going to do. It's going to pull the lumbar segments forward into lordosis. It's going to side bend to that one in particular side, and that's going to rotate contralaterally. And if they're sitting there because now they have this hip flexor tone pulling on that lumbar segment, they're not going to be able to reverse that curvature as they go through the striding process, right? So now we're losing that spring out of that passive mechanism via the discs, the neural arch, all that elastic tissue that we were just talking about, that pliability of the lumbar spine itself. We start losing that too, because now it's locked up because of the tone change in the psoas. So things like that could very easily cause breakdown in the hip, for instance, because now we're demanding more mobility out of the hip joint itself. Or it could just be something as simple as an insertional tendinopathy where the hip flexor attaches, right? So it could be any number of those sort of things, but we have to start to consider like, okay, where is this coming from? And I think by the time this course is over, guys, you'll all look at you'll have patients coming in for whatever the problem is. They'll come in with knee pain and you'll be like, you know what, I should probably look at the thorax. Because it's so common to have problems there. And again, it's just, I think modern life has intervened on most of us at a certain point. We spend a lot of time right here in front of computers. A lot of people have desk jobs. It's not necessarily as big of an issue for those of us that work as PTs, because we get up, we move around, we're working with patients, we're on our feet much more. But my patient load, I work in downtown Denver. I see a ton of patients that sit at a desk for 10 hours a day. And then after that, they want to go do their training for their 5K or their 10K after work. Now they go from a anterior dominant forward flexed posture all day to all of a sudden an extension based dynamic posture like running. And we have to and all of a sudden we expect our body to have that duality, that ability to accept that duality and not break down. I mean, what are we thinking here? Especially when we start getting into, my age range, when they start hitting their 40s, It's just like, is that really something that we should be able to expect the body to be able to do? Go from one extreme to the other, just like that, without developing problems. I mean, when you talk about it like that, it seems to make so much sense. Like, oh yeah, of course something broke down. Look what we're trying to do. We're trying to go from this extreme to this extreme all in the same day. And it's just hard for human bodies to kind of tolerate that sort of thing after a while.
Yeah, that's where it even takes, there's what, okay, yeah, it does take longer to warm up, but how am I just really like warming up for 30 minutes and now I'm going to go to an extension-based activity. So I'm going to warm up for 30 minutes before I do my 35-minute run. It just doesn't happen that way.
Right.
You're not prepping the spine. For many of my patients, I'll look at it as like, if I know this is what you're doing, then you need to be working in extended positions throughout your day. So when you make the transition, it's not just I'm going from a flexed position for 5 or 6 hours, where I need to generate force in extended position. You're not going to do it. You're going to adopt a flexed position forward and run with that. That's your dominant, it's your easiest pattern to be in. And that's kind of where you're going to generate the other problems, either in the thorax, lumbar spine, hip, knee, you kind of gastroc soleus because you're bent, you're putting extra stress on the system.
Yeah, it's tough. It's a tough sell for the body to be able to handle all that sort of stuff, especially with the amount of duration that we want it to.
Yeah, but it's such a pressure valve for those hip and lower back issues to say, okay, yeah, your back is acute, but if I can free up and improve the thoracic motion, mobility, can I get the center of mass over the base of support? If that's not occurring, if they're forward, many times you can get stress off the system without having to poke the system. So the thorax really does that because it centers things. And it's the same with the cervical spine, is that many times it's where is my thorax, or even get into trying to create some type of muscular treatment in the cervical spine.
Yeah. Yeah, and that's a good point, because we didn't even touch on it, and we kind of got ourselves carried away with the gating mechanism here, because you and I see a ton of runners. But it's the same sort of thing with upper extremity motion, right? If we can't gate the motion or unload the stress because we have poor CT junction mechanics, somebody that's an overhead athlete, for instance, a tennis player, volleyball player, softball player, baseball player, et cetera, I mean, I'm thinking more along the line of kind of the weekend warrior at this point. What are they doing? Well, a lot of people play tennis, a lot of people play softball, a lot of people play, they're playing pickleball now, all these sort of things, but they require the ability to produce overhead, high velocity overhead movements, right? And the CT junction acts much the same way for distributing those loads. If we can't unload that shoulder girdle, or any portion of the upper extremity really, through the thorax, we're really putting a ton of torque on this. I looked at I just did a course in where was I for that? Can't remember. It might have been it was in Pennsylvania, a throwing course up in Pennsylvania back in April or May, I guess it was. And we're talking about the force vectors, the amount of torque that goes through the upper extremity with something like overhead throwing. And it's just like when you even look at structures like down in the elbow, like the ulnar collateral ligament, physically, it is completely incapable of tolerating the torque that goes through the elbow on its own, without recruitment of the flexor mass, right? So the wrist flexors. So anytime you have somebody that has increased load going across that upper extremity joint, whether it's the shoulder or down into the elbow, for instance, you're going to start overloading that tissue, because we're teetering on the brink to begin with that sort of motion. The structures there just aren't, morphologically, they're not capable of handling that torque. So that's another thing. It's just like, okay, well, we talk all this stuff about the lower thorax and being able to handle these sort of things with gait, and running and whatnot, but it's the same thing in the upper extremity. You gotta have that happen as well. You've muted yourself, Dave.
Sorry. When we look at like throwing mechanics, bringing that arm back in cock, what do we have going on in the thoracic spine? And how would you describe it, Eric? We're coming back here to throw. We're looking at, what do we have? We have extension, side bend, translation. So you're a right-handed athlete. You see?
Yeah, it kind of depends on It kind of depends on which part of the thorax you're talking about. If we're talking about the CT junction, we're definitely talking about extension, ipsilateral extension, rotation, and side bending is what should be happening on that side, which comes with it its own natural translation. Right? So if I'm right-handed and I'm kind of wound up like this, then I should be right rotated, which would tend to suggest a left rotation, left translation.
Yeah.
Those things have to be able to occur. You know, you start losing one or any or multiple of those, then yeah, you're running into problems. But yeah, I mean, all you have to do essentially is view the activity. You know, Diane Lee always talks about these things as the meaningful task. You know, so you have to be able to watch what the person is trying to accomplish, right? So if they're a runner, you got to watch them run. If they're a weightlifter and they can't squat, you got to watch them squat. If they're a thrower, you got to watch them throw. And then you have to be able to take the process that they're using, the form that they're using, and compare it to what things should be able to do, right? So if we're looking at, okay, you know, we've got an upper extremity athlete here. We've got say a baseball player or something like that. And we're watching them throw and we're saying, you know what, I'm seeing like they're not getting enough trunk rotation available here. So we're going to have to take a look at what the trunk can do. And then you break it down into its isolation, right? You move the trunk and see where we might be coming up short compared to the opposite side. It's not terribly difficult. I mean, you and I did the one with the last group where we were looking at the what was it, the high jumper?
Yeah, it was high jumper
that we had. Yeah, so I've never seen a high jumper come into my clinic. But when you're looking at somebody, you know, it's just a video watching the person run and do their thing, and it's just, you know, we broke it down in what, 15 minutes, something like that. It's just like, okay, so that they get into this position, they have to be able to produce that motion. They get to this stage, they have to be able to produce that motion. And it's just about looking at it and saying, okay, this is what they need. Can they get that individually? That's where you go into your examination process and start breaking down what the body's capable of doing. You don't have to see it directly during their activity, right? So if we're looking at a high jumper, I don't have to have them go do a high jump in my clinic. I just have to know what the body needs to be able to produce to function in that activity. And then I can say, okay, I know these markers. I know these particular body regions are going to have to be able to produce this amount of motion. If they can't, then we're running into problems. Then I can go in and isolate that body region and look at that movement, see if they have it. If they don't, all right, now I've got a target. Now I've got something I can work on.
Yeah, and that's kind of where we, understand the biomechanics and just, really trying to be familiar with them when you go into the course, because it'll help you solidify it once you're in the course. You may not have it memorized by the time you get in there, and that's fine. But definitely be familiar with it. Read the article we sent out, review some of the coursework. That helps, because I look at this thrower, it's the first thing I think about. It's like, okay, well, I have anterior shoulder pain. It's, what's my thorax giving me? Because that's the pressure valve. I have to go down lower. Is it hip rotation? But if this was a thoracic driven kind of shoulder, that's what we'd end up seeing. Does this person not being able to extend or translate or rotate through this upper thoracic region? But what they're going to do is they're going to default down to the next joint or the next joint, in which case those other joints become much more vulnerable.
Yeah.
And if I can tell if all those joints, let's say I go and I do the biomechanical exam, and those joints are moving okay and they're still not moving well, then it's probably a motor pattern issue. So understanding what the joints are giving me, even when I find a normal system, is super helpful, because now I know that, okay, they have an aberrant strategy. So is this coming from somewhere else, or do I really need to work on retraining their patterning technique? If all the joints are giving me the appropriate amount of motion, there's not a restriction, then it's there. I'm on to the next joint, TL junction. Am I down into the lumbar spine or hip? Or is it now in a motor control issue, how they're initiating the motion?
Yeah, and I think, especially when we get into the peripheral course, I think we see this sort of thing a lot. What you're talking about here is that ability to view the dysfunctional or the painful area and relate it to the other areas of the body. Where can these stresses start coming from? Because we have to think about it in a certain number of paths here, I guess I could say. Joint planes, for instance. So for instance, in the lower extremity, we see this one a lot, where we get subtalar joint issues that will affect the knee. those two joints relatively are in the exact same plane, right? They're both going to be in the transverse plane, so they can affect each other. You know, and sequencing of movements, you know, when you're doing something, so for instance, an upper extremity movement, you know, where does the movement initiate? Does it initiate through the trunk and then move out through the arm, or is it initiated in the arm and moving into the trunk? You know, and so kind of tracing those things back, it becomes real important to be able to do that sort of stuff. Because we, as manual therapists, the thing that we should always be looking for is the stiff segment, right? That's the thing that we always want to be finding so that we can treat it. We can get it moving better. We can alleviate stress on other, on the painful regions or other dysfunctional regions. And that tends to give us the opportunity to re-educate the patient's movement patterns, improve neuromuscular recruitment and all those sort of things, and get the patient back to kind of a resting neutral state, right, where they're functioning normally. But we can't always do that if we can't relate one region of the body to the other based on the activity that they're trying to do. So it's a tough thing to do sometimes, but it's definitely something that gets easier with practice. So yeah. Yeah. So any questions from anybody here? I don't know that we need to really jump into another thought on this stuff today, but everything we're saying hopefully making sense, or at least enough to the point where you're going to have at least some background of knowledge here coming into the class next week. I will not be able to be on the call next week. I'll actually be on a plane on my way out there. So one thing I do want to mention is we are, or at least in the planning that I'm making now, I have to get my agenda out to Travis. I'll get that out to him today. But we do plan on doing a bit more clinical reasoning in this course. So there will be a little bit of needling work that we're going to do kind of toward the end of the course here, for a few hours. And, you know, so there's a few things that I'm going to request from somebody. It's easier for somebody there to bring needles and other needed paraphernalia to the course than it is for me to bring it with me on a plane. Going through DIA is like trying to walk into the Pentagon sometimes here in Denver. So carrying needles with me in my bag, since I only do carry-on stuff when I travel for this stuff, would be a bit of an unnecessary thing, especially if we're counting on me to have that stuff when we get there. If TSA decides they're going to take it, that doesn't help us. So if we can make sure that we have some of that sort of stuff available to us in the learning center there, that would really help me out. And we'll probably have to have some additional consent forms done, since it is an intramuscular technique. So we'll have to consider that as well. And I can talk to Travis about that as well. So.
And I know we're going to do it going forward. So yeah, just we'll confirm that they're good with us doing it in this course. So.
Okay, that sounds good. All right, good. So I won't talk to you guys again, but I'll see y'all Friday afternoon. We'll get into all this stuff, and it's a good course. I love this course. I think you guys will learn a lot. But yeah, we'll make sure everything seems to make sense for you.
Yeah, it's a really cool course.
All right.
All right, guys. Be good.